Thank you very much. I really appreciate the opportunity to come here and talk to you today. I love to talk about dementia, and I kind of like to hear myself talk, so it's a really good fit. So for the next hour, you just have to listen to me and stay awake. Hopefully I won't eat this thing. And I guess this is how we do this. Okay, that's my logo, my card. And what we're going to do today is a quick run-through of some of the increased ways you and your facility or your company can be held liable for injuries, pain, suffering, death. If you have residents or clients with dementia, and you all do, whether you think you do or not, they're there. They're just high functioning right now. And this talk today is actually just a segment, a 6-hour talk that I do for a company called Health Ed on a nationwide basis. So I tried to put as much information in here as possible. So I'm going to speak quickly. Right after the talk, I'm going to go back down to my table down there. So if you have questions or want to catch me or talk about my books or look at my video outline or whatever, catch me down there. So as I see it, there are 3 areas where most of your liability comes from. Okay, you've got family members, state surveyors, and your own staff as they interact daily with those elders with dementia. Let's talk first about how family members might increase your liability. Okay, be honest with me now. Are there maybe 1 or 2 people, family members, that when you see them coming through your front doors, you want to run and hide? Do any of you have anybody like that? Why do you want to run and hide from these family members? Is it because they're demanding? They have unrealistic expectations about what you and your staff can do for them? Yeah, that's probably it. What so often happens when these family members come to you on a daily basis and they're unrealistic and they're demanding and they seem to have a chip on their shoulders is that when something happens to their loved one, they will usually blame you. And when they think that you've dropped the ball and their loved one is suffering because of that, they're much more likely to call an attorney to help make them feel better and to punish you. So what can you do to reduce the likelihood of that happening? You can change the way those family members feel about you and your company or your facility. I want to tell you how you can turn those demanding, not so nice people into friends. It's actually very simple. It's not easy, but it's simple. Now, here's a list of stressors that these family caregivers have been under for years sometimes before they ever come to your facility. And you look at all of those things and it's usually based on guilt. And then that guilt is compounded when they admit their loved one to a facility, because they may have promised to never ever do that to their loved one, but they just couldn't handle them at home any longer, especially with dementia. So here's how you turn those people into friends who won't be so quick to sue you when and not if something happens to their loved one. First of all, I want you to, next time you see that person coming in the door, instead of wanting to run and hide, see that person with a big sack on their back. And in that sack is a brick. And each of those bricks has one of those things on it, one of those huge burdens written on it. And you know what? This person doesn't even know that sack is on their back. They did lots of studies and they found that caregivers under those stresses, after they admit their loved one to a facility, those stresses don't go away. They still carry them around. So see them with that big sack on their back. Get all your staff on board with this. And you say to your staff, this is what we're going to do. Here's the plan. Every single time you see Cindy come into the facility, you're going to go up to her and you're going to greet her warmly and you're going to tell her something nice about her loved one. Good morning, Cindy, it's good to see you. You know, your mom gave me the biggest hug this morning when I got her up, and she had a big smile on her face. How does that make me feel? That makes me feel wonderful. And what do I think about you for telling me that? I think you're wonderful. Okay? So every single employee, when they encounter me, is going to tell me something nice about my loved one. And then you're going to take this person aside to a quiet area. I know your days are busy, but this is worth it. Take them aside to a quiet area, sit them down, look them in the eye, and say, I want to know how you're doing. How are you handling all of that stress? You know, it may be no one ever asks them that. And if they do ask them that, they're fine, I'm okay, everything's okay. They can't go there. It's just too painful. So then you're going to open Pandora's box, and you're going to say, what can I do to make your life easier? Now be prepared to write down a whole laundry list of complaints. That's okay. I guarantee you there are some complaints that are valid. You're going to write them all down. You're going to promise to work on them with your staff. You're going to meet with your staff and say, let's brainstorm. How do we address each one of these problems? And you're going to promise to work on that. And then the next time you see that loved one come in, you're going to take them aside again. Before they can utter one complaint, you're going to take them aside again and say, how are we doing on this list? Have you had a chance to do something fun for yourself? Or do something relaxing for yourself? Okay? And what this person is going to start thinking is, wow, they really seem to care about me. Not only do they care about my loved one, they seem to care about me. And they start looking at you as a friend. This works. I have done this. We had a couple in a dementia-dedicated assisted living. She didn't reside there. Her husband had dementia, but they were high-power jobs in New York City, very highly educated. They came from England. She would come into my office every day. Well, you know, David's tea isn't being served at the proper time. Really? Tea? Yeah, that's not what I said, but that's what I thought. I mean, things like this every single day. And I wanted to run and hide every single time I saw her coming. So I finally said, okay, get a grip. Let's do something about this. Let me see if I can turn this person around where she's not driving me nuts every day. And so I instituted this program with her, and it worked. And I knew it worked the day she came in and said to me, do you think it would be a good idea if I got a cat, a calico cat, like David and I used to have? And do you think I should bring it in to visit David? I said, I think that's a wonderful idea. And she did. And I remained friends with this woman after her husband died. I would meet with her socially. That's how close we became. So it works. Okay. The next big area comes from your surveyors. There's kind, helpful, caring people that enter your facility with a big smile and lots of warm fuzzies, right? Do you know any of those? No. Okay. Well, some ways that you have liabilities from state surveyors are resident-to-resident contacts. How do you prevent resident-to-resident contacts when you have a bunch of adults acting like 5-year-olds? You and your staff anticipate them. That's a big thing. If you know Alice, who has dementia, doesn't like George, who also has dementia, for whatever reason, she starts to yell at him and tells him to get away from me before I get a gun and shoot you. Maybe he reminds her of someone in her past. So if you know this, then you and your staff have to make efforts to keep them apart. Maybe if you just did something simple, like ask George to put a hat on, that changes his appearance a little bit. Maybe that's enough to get Alice to not scream at him. Find the trigger behind what's going on with Alice. Why is George evoking these feelings in her? If a resident takes ownership of the big comfortable recliner in the living room and gets upset if anyone else sits in it, what do? Hope that nothing happens? No. That recliner has to disappear. It has to go away. He cannot have ownership of it, because if he does, he's going to be dragging that sweet little elderly lady out by her hair when she sits in it. And then you've got a lot of problems to deal with. If Elsie and Sarah, who both have dementia, are always arguing with each other when they're seated at the same table for meals, you have to separate them before one of them decides to do something about it. Teach them a lesson, okay? Another thing to worry about with surveyors, checking the MARS for use of PRN psychotropics. They do not like to see psychotropics used. Why? Because psychotropic use means increased visits to the ER, increased falls, increased injuries, and all of those psychotropics have black box warnings. And there's not one single psychotropic out there that is FDA approved for the control of behaviors in people with dementia. Not one. They're all being given off-label, and they all have black box warnings. So the state knows this is not a good thing to be giving these psychotropics. And they call them dementia-related behaviors, or DRBs. And there's a definition there of what a DRB is. And they even go so far as to say, doesn't include psychiatric disorders, diagnoses with certain behaviors like those seen in those schizophrenia, hallucinations, delusions. So this just means people with dementia acting like people with dementia usually do. So if this person with dementia really does need the psychotropic, how do you get around that surveyor who thinks they may not need it? Document, document, document. The doctor has to say exactly why he feels that psychotropic medication is needed. And the staff has to document every single time that other interventions were attempted and did not work. So they use the psychotropic as a last resort. So the state isn't going to say anything about that as long as you have that documentation to back it up. So what do you do about those dementia-related behaviors? How do you successfully de-escalate the agitation or anger of an elder with dementia? The biggest thing is your staff needs to know what's familiar for this resident, what helps calm them down. And I'll talk a little bit more about this in a few minutes. But the sensory stimulation room is a great thing to have in a facility. How many of you have sensory stim rooms? Nobody. Okay, think about having one. The evidence is overwhelming about how effective a room such as this is, especially for elders with dementia. But even if you don't have that many elders with dementia in your facility, I'll bet you have a lot of people in your facility with depression. And this type of stimulation has been shown to decrease depression. So, what is a sensory stimulation room? Simply a room that has all of these wonderful items in it, and you have to keep comfort and safety in mind. Staff person would need to be present with an elder with dementia. Think about these things in this room: a recliner, rocking chairs, music sound system to use with either white noise or to play chosen music. So if Bill, who loves country and western, is starting to get a little agitated, and you know he's not just going to settle down on his own, so you take him in the sensory stimulation room and you put on a tape of country western music that you know he likes, and he's going to settle down. Aromatherapy unit. A lot of people believe this works. Some people say it doesn't work, but it smells good. You know, lavender is supposed to soothe, and orange is supposed to stimulate. Solar projectors, that can be pretty pricey. A solar projector is one that can project an image on the wall as well as the ceiling at the same time. But if you can't afford that, just any kind of projector. Fiber optic light spray, bubble tube. They have very large freestanding floor models where these softly moving colored bubbles move up and down. think of, you know, on the order of a big lava lamp, okay? And then they also have the smaller desktop models. Tactile objects in this room, possibly a life-size baby doll in a small cradle, small fan or breeze machine, wind chimes, hanging colored scarf, or a sheer curtain on the ceiling. Why on the ceiling? Number one, you don't want them getting a hold of it. Number two, people with dementia start looking down and they never look up and they never reach up. So they lose the ability to do that eventually. And they found that people in a sensory stimulation room, when there are things on the ceiling, they will look up and they will reach up. And so it's good exercise for them. A painted mural on one wall. Bubbling fountain, but you have to realize people with dementia would probably want to get their hands in it. Wave machine, lava lamp, but people with dementia have vision deficits, so it has to be at a level that they can actually see it. And if you don't want them touching it, then you have to put it in such a way that they can't reach, you know, behind a glass plastic screen or something. Something for restless hand motions. The window in the room should be covered to prevent distractions. Not that you want it dark in the room, but lowered lighting. So if you have a window with a shade that's open, it's going to detract from the things in the room. Documented benefits. Decreased agitation, repetitive movements, and vocalizations for hours afterwards. Hours! Less depression. Blood pressure and pulse rates are altered. Better food and fluid intake. Decreased insomnia and wandering. So if you've got Bill who gets up at 3 o'clock every single morning, because he used to work night shift, that's when he's used to being up and working. How do you get him to go back to bed? Because he's probably not going to go back to bed just because you want him to go back to bed. Take him into the sensory stimulation room. Increase staff job satisfaction, decrease burnout. Do any of you have staff turnover? Yeah. Okay. A better question would be, does anyone not have staff turnover? So this helps the staff feel better. Families are happier. You know, they come into the facility and they often don't know what to do with their loved one. And so take them in the sensory stim room and they see, okay, mom really likes to look at this. And so they enjoy doing that with her. Better range of motion. They found that people with dementia who had stopped speaking in complete sentences when exposed to a sensory stimulation room on a regular basis started speaking better. They were speaking more in sentences. And they participate in activities more often. Room items should be child-proof. 15 to 30-minute sessions can decrease a person with dementia's tendency to wander for up to 4 hours afterwards. So all of you that have assisted living facilities that are not secure, or nursing homes that don't have a secure unit, how do you keep those people with dementia from going outside, wandering away, eloping? This is a great way to do it. Daily sessions decrease depression. Studies show when they put a person with dementia in a sensory stim room prior to an uncomfortable procedure like a bath, you know how they all love to take baths, they tolerate it better, less anxiety and combativeness. Staff do need some training how to use the room appropriately. They would need to know that if you have a mixed population and Ethel is in there and she doesn't have dementia and she's enjoying watching a movie, and Bill is getting agitated, he has dementia, people with dementia would take precedence because Bill can't settle down on his own. He needs help. And Ethel needs to understand that. Everyone can benefit. Multiple residents can use the room at the same time, should be able to seat 2 people comfortably. Now, if you don't have a room that you can dedicate to this, make up a cart. You know, they have those carts with power strips on them. Similar items on there. Wouldn't it be nice if you had a hospice resident lying in bed, actively dying, to bring that cart in there and put a shot of something, some calming scenes on the wall, use the aromatherapy, play her favorite music. Isn't that a much nicer way to die than just looking at the four walls and the ceiling? Celebrate holidays, use it for activities. You can use different scents of aromatherapy in a diffuser. Okay, more things to do in order to decrease liability from state surveyors. Ongoing staff dementia training. This is just huge, and I'll talk more about it in a minute. Records of elopements from your facilities. Surveyors will be looking at every incident report on elopements, and they'll be asking you for your protocol. Do you have one? Do you hold elopement drills that you practice just like a fire drill? How many of you do this? Good, I'm glad to see this. You all need to be doing this, because it's not a matter of if a person with dementia wanders away from your facility and elopes, it's a matter of when. So what happens if you don't have that protocol and you get the call at 3 o'clock in the morning? Bill's gone, I can't find him, I don't know where he is, we've looked all over the place. What do you say to this staff person at 3 o'clock in the morning? Especially if they say, I've already called the police. Oh, yeah. So this is why you need a protocol, okay? Has every room been searched, including closets, under beds? Have they searched outside yet? What personal items for that person with dementia are missing? Hat, coat, glasses. If Bill's pajamas are lying on the floor, it's safe to assume he doesn't have them on anymore. He's either naked or he put something else on. At what point do they call police? Or do they not ever call police? They leave that up to you. At what point is the family called and who makes that call? This all needs to be put into a protocol on paper, on a clipboard the staff can grab and follow along and fill in the blanks. Put the phone numbers right on there, because when they're panicked, they may not even remember your phone number and they waste precious minutes trying to find your phone number, okay? Sentinel events, another liability from surveyors. And nursing homes are more familiar with this term than assisted livings, but it's certainly not exclusive to nursing homes. And there's the definition there from JACO. And what you have to realize is that last little bit that says, or the risk thereof. So if you're in assisted living and you had somebody elope and you have no elopement protocol, the risk of excessive danger or death to that resident is very, very high. And even if you successfully get them back in, you send that report, and that is a sentinel event because they could have easily died. So you don't want sentinel events happening. Okay. Staffing levels. You know how surveyors always check these records, and if you don't have appropriate staff on board, if something adverse happens with an elder with dementia, that may be enough reason to close your facility. At the very least, cause a huge uproar. Appropriate frequent activities for elders with dementia in any stage. Activity calendars are important to have visible and itemized, posted. Woe is you if the surveyor is there and sees hand massages and manicures on the schedule for all non-ambulatory elders with dementia. It's not being done at the time it says it should be being performed. Another liability, when people with dementia become combative and you have to send those incident reports in. If you have a high level of doing this, of incidents of combativeness, the surveyors are going to be looking at your staff dementia training as well as documented ways you de-escalate combativeness, because surveyors know that other things than medication work with elders with dementia. That means your staff has to know what those other things are. And what you want to strive for is a collaborative relationship with your surveyors. Tell them everything. How many of you think that's possible? Collaborative relationship. I typically don't see many hands go up with this. And you know, we used to hate the surveyor that came into our facility until we got a new director. And I saw the way that she changed that man. He was actually a nice person. And she did it by this. She called him for everything. Hey Matt, we're thinking of getting those Velcro stop signs up around the exit doors. Is that okay with you? Hey Matt, this little incident just happened between two residents, and I'm not sure if I even need to write out an incident report. What do you think? She called him about everything. She was excessively friendly to him. He became a nice person. All because of that. Think about that. Wouldn't it be nice to have a collaborative relationship with your surveyor? Okay. Earlier I mentioned one huge area of liability with surveyors is staff dementia training. And you know, these people that you have hired don't automatically know how to interact appropriately with these challenging elders. And they need to be educated. They need to see how it works. Intensive and ongoing dementia training will be the single biggest thing separating your facility from a lawsuit or having your facility shut down by the state. Dementia training. Okay? Here's a scenario. It demonstrates how one simple action by an elder with dementia can cause an uproar in your facility multiple times a day when the staff hasn't had proper dementia training. This is about Ethel and Bill. This facility doesn't have a dedicated dementia unit, so Bill, who has dementia, keeps going into Ethel's room. Now, Ethel doesn't have dementia. She hates Bill because he keeps coming in her room, and he immediately starts going through her closet. What's he doing? He's looking for his jacket. Every day he does this because he thinks this is his room. So you're working down the hallway with another resident, and all of a sudden you hear, "Get out of my room! I keep telling you to get out of my room!" And you know exactly what you're going to find, right? Because you found it many times before. So how do you go into Ethel's room and convince Bill to happily leave Ethel's room? Might you say something like this? "Bill, sweetie, come on with me now. You know this isn't your room." You know, just because they act like children, we must never treat them like children. And they know. They know when they're being treated like a child. We had one lady in our dementia-dedicated assisted living. She was only about this big. Very feisty little lady. I'll call her Aunt B. She was standing outside my office one day talking with a staff person, and this staff person was twice her size. And I heard the staff person say to her, "Now, you know, Aunt B, you can't do that anymore at your age." I looked up in time to see Aunt B go like this. She had to look up because she was so short. Shook her finger in this employee's face and said, "Don't you talk to me that way. Just because you're bigger than me doesn't mean I can't whoop you when you need it." And as she stalked away, she smacked her on the butt with her pocketbook. She knew she was being treated like a child, and she didn't like it. Now I ask you, if dementia had robbed her of the ability to say those words, would she still have recognized she was being treated like a child? Yes. Would she still have been angry? Yes. What would she have done? This is what people with dementia do when they can't make their needs known. They strike out. Okay, maybe you would say, "Bill, how many times do we have to remind you that your room is the next one down?" Is Bill ever going to remember where his room is? No, he has dementia. And unless they specifically ask for it, it serves no purpose to reorient them. How about if you say, "Bill, come on now, if you'll just come with me, I'll take you to your room," and you tug on his arm. What do you think that's going to accomplish? Impatience is easy, and staff need to learn patience and how to properly redirect this elder. Maybe you say to Bill, "Bill, you have got to stop this right now." What's another name for that? Verbal abuse. Maybe you say, "Bill, come on out now, you're upsetting Ethel again." You think Bill's going to agree with that? He thinks this is his room, and he's likely to say, I don't know why that crazy old lady's hollering at me. If she doesn't shut up, I'm going to go over there and shut her up. And someday he's going to do that before you can get back there and move him out of that room. And you know what? If Ethel knows she can respond in this way, she'll keep doing it. Remember, Ethel doesn't have dementia. She can learn another way. She can learn to both call Bell, and she needs to be taught that. So none of these improper responses, treating them like a child, lecturing, impatience, anger, blame, is likely to work effectively to get Bill to happily leave Ethel's room. And yet, this is the kind of staff interaction you see on a daily basis in so many facilities. And families and surveyors can see it too. A proper response to this scenario might be something like, Bill, there you are. I have been looking all over for you. You're the only man in this whole place that can help me with this problem. Can you come with me, please? Is that likely to get him out? Something on that order. Or, Bill, I'll bet you're looking for your jacket. I know exactly where it is. I have it. Come with me. And then you have to go back and educate Ethel. Okay, I have several excellent training options at my table if you want to stop by and get some information. At least pick up one of my cards and visit my website. You can see excerpts of the training options there. I want to say a couple quick words about staff neglect and abuse. They're both topics that you're very familiar with. And when you have elders with dementia in your facility, they are the most likely people to be neglected and abused because they can't tell anybody about it. But families notice, visitors to your facility, including surveyors, can often see when staff are neglecting people with dementia, not necessarily because they're mean, nasty employees, but because they don't know any better. They haven't been trained. Are these neglect? Lack of bathing? Yep, leads to indignity and poor hygiene. How about poor hand washing techniques? I mean, we all know we're supposed to wash our hands, but did you know that can be considered neglect if you don't use the proper technique? Leads to spread of infections. Lack of assistance with participating in activities of interest. That's neglect because it leads to withdrawal and isolation. How about ignoring call bells or cries for help? How many times have you walked into a facility and you see that little elderly lady in her jerry chair? Help me, please, help me, please, help me. And you go over and you say, what can I do for you? Hello, dearie. Do you need anything? No. It's just that tape endlessly playing in her mind. But this website is saying, and is educating families out there, that when you see this going on in a facility, it's neglect. One more thing for you to worry about. Abuse, as you know, can be multiple things: physical, mental, emotional, and again, it's more likely that those elders with dementia are the victims, and when they are, your liability increases. So having talked about improper interactions by employees to people with dementia and neglect and abuse, in the world of dementia, tell me how you feel about this statement. Read that. How many of you think that's true? 100% of the time? Maybe not quite 100%? Yeah. I would say 98% of the time, this statement is true. There are just a few rare instances when you can never see it coming, but they are very rare. So you have to give your staff that tool of education for interacting appropriately with these challenging elders. And now that you know better, by not giving your staff the tools they need, you are perpetuating the chaos they don't even know they're creating. I want to tell you a quick story. It's actually the story that led me, the incident that led me into dementia. I was working night shift. I was training to night shift in a skill facility. Anybody ever work night shift? And you have brain damage too, like I do, right? Yeah. I swear it causes brain damage. Anyway, I was being trained, oriented by a nurse and an aide, both of whom had worked there for many years. And we go into Belle's room. Belle is this skinny, scrawny, little elderly woman in the later stages of her dementia. I didn't know this woman. They walk in, they flip on the overbed light on high and say, "Belle, it's time to change your brief." And they pull the quilt off of her tightly curled little body. And Belle does what you or I would do if somebody did that to us. She screams and reaches for the quilt. They were ready for her. The aide grabbed her wrists, and the nurse was dodging her kicking feet to get the wet brief off of her. I'm up at her head trying to calm her down, and she just would not be calmed down. She was kicking, biting, screaming, trying to scratch, anything she could think to do to make them stop what they were doing, because she didn't know why they were doing that to her. They finished, put the quilt back up on her, turned and walked out without another word. Belle was crying. I quickly whispered a few words of comfort to her, kissed her on her forehead, turned the light out, went out in the hallway. I noticed the aide was rubbing the back of her hand where Belle's nail marks were clearly visible. I said, "There has got to be a better way." And the nurse said, "With her? No, she's always like that. You can't do a thing with her. We ought to get combat pay for what we have to put up with from these people." That's what she said. I said, "Well, I'm sorry, but I'm going to have to find a better way. This is not acceptable to me," which immediately endeared me to my new colleagues, if you can imagine. So I read Belle's chart, I talked with her daughter, I found she loved music, she loved to sing, she would respond to a kind, gentle touch. From then on, every night, I would go into Belle's room by myself, get the wipes in my hand, run them under the hot water, ball them up to keep them warm, go in, turn the overbed light on low, and I would sing to her. I would sing, "Belle." Every single time, she would sing back to me, "Yes." And I would smile so that it would carry through my voice. I'd say, "Hi, it's Cindy, and I'm here to take that wet brief off you and put a nice dry one on." She'd usually start to say, "Oh, I don't want to." And I'd say, "Oh, I know you don't want to, but you know what? I'm going to keep you nice and warm, and I want you to sing with me." And I'd put one of those lap robes right over the quilt, and I would start singing. It was usually Amazing Grace. And I wouldn't get far, and she would start singing with me, and I would pull the quilt down underneath that blanket throw, change her, use the warm wipes on her, we would be singing, put the quilt back over her, she would be smiling. She never, ever left her nail marks in my hands. If I tried to tell those two employees they were causing Belle to act that way every single time they interacted with her, they would have looked at me like I had two heads. They know how to take care of these people. They've been doing it for years. This is why management needs to set the bar. That was abuse. They need to set the bar. Give the staff the training they need to properly do what they need to do. Okay, intensive initial dementia training, make it ongoing. Be sure to continually reinforce it, because multiple studies have shown that once the staff get dementia training, their comfort levels, their satisfaction, their skills improve following the training. But if it's not continually reinforced by management, studies show about 8 months down the road they will have reverted back to their previous behaviors. So all that time and money you put into the training was for nothing. I want to talk now about some specific challenging behaviors exhibited by many elders with dementia and how to handle them. I don't have much time to go into detail or provide stories like I love to tell, but I'll touch on some of the most common problems seen by staff. Wandering in and of itself is great. I mean, you want them up walking, they just need a safe place to wander. Here are some options for some secure, more secure ways to keep your residents in your facility. But you have to realize if any of these utilize GPS, if it's a real cloudy day, or you got lots of mountains or tall buildings around you, GPS signals might be useless. So that's something to take into consideration. Project Lifesaver through the Alzheimer's Foundation of America, this is probably, as far as I know, the best option out there. It's a wrist ankle device that emits a tracking signal, and it's not GPS founded, but the local police need to have the equipment in order to track and locate the person, and that's not inexpensive. But the recovery time is average 30 minutes. 30 minutes! That's huge. I was a member of a wilderness search and rescue team for a number of years in the State College area, and when these elders with dementia wander away, they can die so much quicker from exposure, either too hot, too cold, whatever. So the cost includes training, and grants are available, and you can do like fundraisers in the community to get the money. So, you know, maybe a couple of facilities in the same area can go together and do it. And then I think the police go around and make sure that the batteries are changed in the bracelets on a regular basis. That, as far as I know, that's the best option. Hoarding and hiding food, very common behavior. And sometimes it can stem from paranoia. Well, I have to hide this here because if I don't, that woman who lives in my room will steal it and I'll go hungry. Never confront them about that, because you're just demeaning them and treating them like a child, and it's not going to help. Families have to be aware of the problem, and they also have to be aware that you are going to do regular searches throughout this resident's belongings in the room. And if the family has a problem with that, then they have to sign an agreement that they'll come in and do regular searches and make sure they're doing it, because this is a danger to that resident that's going to eat something that they shouldn't. And if your staff is doing the search, you should have 2 staff people at the same time doing it, so if that bracelet disappears, then they have, you know, somebody to say, no, we didn't take it. I was helping an elderly lady get undressed for bed one night. She had a big baggy sweater on, and I took the sweater off, and an entire piece of chocolate cake fell out of her sleeve. She said, oh, I wonder where that came from. I remember thinking, what a waste of a perfectly good piece of chocolate cake. Refusal to take meds. Never force them, that's abuse, and besides you'll just wear it. Begging, bargaining, or pleading. We had a resident who, she didn't like to take anything, but mainly fluids. She didn't like to drink water. And I knew this, and so I would, at break time, I would usually try to, or snack time, go out of my office and I would hand her, she'd be sitting there with her cookie, and I would hand her the glass of water, and she'd say, no, I don't want that. Oh, please, Louisa, please, for me, just one sip, please. Oh, okay, she'd say, and I'd set it out of sight for just like 5 seconds, because she had no short-term memory. I'd do it again, and I would get that whole glass of water down in that manner, by begging her one sip at a time. So your staff have to be willing to do that. Don't argue, walk away, try later, have a different person try. You can't just give up and say, well, she wouldn't take them. And if nothing else works, crush and put into food or drink with the permission and awareness of the healthcare power of attorney. You have to be aware, and your staff needs to be aware, there are a number of medications you cannot do this with. You could directly contribute to the death of your resident if you do that with the wrong medication. So they have to work in conjunction with the pharmacy on that. Reduce the number of doses per day. If you're having trouble getting them to take that blood pressure medicine 3 or 4 times a day, it's a generic brand, get the brand name that you might only have to give once a day. Think of all that time and effort you're going to save. Even though it is a little more expensive, the compliance will be so much better. Some meds come in liquid form, Solutabs. What a wonderful invention. Don't you wish all meds were like that? Instantly dissolve on your tongue? Chop up calcium chews, brilliant idea. Here's your piece of candy, rather than that horse pill that they usually get. Calcium comes in. I had one resident who didn't like to take meds. I learned that if I said something to her like, well, you know, your son Jeff is going to be calling me today to ask me if you took your medicines. You know how he doesn't like that when you don't. Oh, all right. And she would take them. You do whatever you have to do. Refusals to bathe. This is, I'm not going to go through these one by one. It's a huge problem in facilities, I know, but because of the time factor, I wanted to include it in my slides so you have it in your handout, so you have the information there. It's also a free download from my website. Realize that on my website, this is written more for families who access it, so the suggestion, take a shower with them, is probably not something you want your staff doing. There are 6 slides here, so I'm just going to click right through them. But check those out on your own time. Paranoia can stem from the brain damage, or it can be a coexisting psychiatric problem. It is critical to maintain their dignity and appear to take it all very seriously. Even if it's something that you really need to laugh about, it's so ridiculous. You have to appear to take them seriously. Validate their feelings and emotions. I am so sorry you're feeling this way. You know, I would be upset too if that happened to me. If they're targeting one person, they're paranoid about a certain person, that person needs to disappear from their sight. They will not settle down as long as they can still see that person. That's the same with agitation and combativeness also. Use magic phrases. I will help you. I know just how to fix this. You say that to a person with dementia and they think you're on their side. Agitation. People with dementia will always, always, always read your body language before they listen to your words, because the words don't all make sense to them anymore. So you must remember your body language. Try to find the trigger behind the action. I had a friend who had a dementia-dedicated assisted living facility in Virginia, and she told a story of a man who was a concentration camp survivor and was admitted to her facility. They very quickly discovered that when they played certain pieces of Beethoven's violin music, this man had a catastrophic reaction, because that's the music he was forced to play. So guess where he thought he was every single time he heard that music? That was the trigger. After validation of their problem, try to redirect them into an activity. You don't just automatically say, oh, you know, that's okay, I'm going to take care of it, come and do this now. No, you have to take some time to give them some strokes, get them settled down, and then change the topic. Bring up a favorite memory. You see Bill starting to get agitated. Your staff needs to know this. Bill's not going to settle down on his own. So it's, hey Bill, what's the name of that dog you used to have? You've heard this story 1,000 times, but you know Bill loved that dog. He has pictures of it in his room. Oh, that's right, his name was Scruffy. What kind of dog was Scruffy again? People with dementia can only focus on one thing at a time, and if Bill's agitation is not being caused by pain, or he's working on a UTI or something, he'll settle down when he's talking about something that he loves. If they allow it, gentle touch or a hug. Harry used to come into my office sometimes. He'd be wringing his hands and he would just be so agitated, and he couldn't tell me why, because he would stutter when he was upset, and that would make him even more upset. And I'd say, oh, Harry, you look like you're upset. I'm so sorry. Could you use a big hug? I sure could use a hug. How about it? Can I give you a hug? He would always say yes. I'd give him a big hug, and I'd be patting his back, and he'd be patting my back. And then after about a minute of this, he would go, and he'd be okay. Never underestimate the power of a hug. Shouting and screaming repetitively. Is this a new behavior? If it is, you're going to be checking for a UTI, for pain, or some other trigger. They did a study where a bunch of elders in late-stage dementia in jerry chairs were doing this behavior. and they gave them all fleece-covered hot water bottles, and they stopped. And they thought, well, maybe they're cold, so try covering them up. Know the person and what they enjoy. One little lady was shouting up a storm one day, and I went over to her and I leaned down and I whispered in her ear. I didn't try to outshout her because I knew that wouldn't work. Had to do it 3 or 4 times. I just whispered her name. She finally stopped. She looked at me. She said, "What?" I said, "Hi, how are you?" She said, "I'm okay. How are you?" I said, "I'm good. Have you seen these new fish in the aquarium we got?" "No." She said, wheeled her over there real close so she could see them. It stopped the shouting for a while, and that's probably all you can hope for. I broke into that endless loop playing in her mind with another activity. But realize that this behavior is going to go away as the dementia progresses. And there might actually come a time when you wish for it back again, when they've progressed to that point. Exit seeking. You know, these elders can often read. They know what EXIT means, and they know this isn't home, and they want to go home. You can try therapeutic fibs. We don't call them lies. We call them therapeutic fibs. Sometimes telling them, you know, your wife is going to be here very shortly, and if she comes and you're not here, what am I supposed to tell her? Something, as long as you know this person is going to forget what you said in a short while. Okay? Now remember that body language thing. If you try to avoid lying to a person with dementia every single time, you have to come up with some kind of something. And if you're trying to think of what to say, they're going to read your body language and they're going to think, she's lying to me. She's trying to think of a lie. Okay? So therapeutic fibs are often what you need to resort to get them to comply, especially if it's a safety issue. I'm not advocating automatically telling every person with dementia a therapeutic fib just because you want them to do something, but it is a valid way to help get them redirected. Redirect to another subject, disguise exit doors. You know, if the exit door looks like a door, they're going to keep using it. If you put wallpaper that's on the walls on the door, then they're not going to see the door. Maybe the border, the chair rail border, carry it across the door. In our facility, we got permission to Velcro up those stop signs across the exit doors, drastically cut down on the people trying to exit through the doors. But we had one lady who loved those stop signs, and she'd go around and collect them. The Alzheimer's store, you ever heard of that? It's a website that has door murals, has a couple door murals where you put it on the door and it looks like a bookshelf or something. So the point is to make it not look like a door. Possibly use those stop signs if you have permission. Take them for a walk outside. If they're antsy and they need to walk, take them for a walk. Be sure to have that elopement plan. Combativeness, often due to inappropriate staff interactions. The goal is to prevent agitation from escalating into combativeness, and your staff needs to know that if they are getting agitated, they need to stop what they're doing, step back, and think, oh, is this going to be my fault if she gets injured or injures me? And what can I do to change this? Watch the body language, apologize and validate their feelings. Always apologize because they're never wrong in their mind. Please tell me how I can help you. And don't argue with them. I did that early in my nursing career one night to a gentleman with dementia who wanted to go outside. He was looking for his wife who was in the nursing home wing just down the hallway. And I told him that. I tried to reorient him. Yes, she's right down here. Come with me. No, she's not. And he fastened both of his hands around my neck because he was so sure that he knew the answer. Luckily, there was a guard standing there to pull him off of me. But I learned a valuable lesson that day. Disrobing in public. You know, those social barriers in their brain have been destroyed. They would not do this if they had their right mind. So maintaining their dignity is paramount. Do not shame, embarrass, or draw attention to them. Is there a trigger behind this behavior? Is it too hot? Is her clothing too tight? One woman in our facility never disrobed unless she was impacted. And then she was uncomfortable and she started taking her clothes off. Packing repeatedly. They do feel better when they think they're doing something that's going to get them home more quickly. You know, it's okay if they pack. They're not hurting anything. You unpack it only if they're not present to see you do that. Maybe hiding the suitcases, but then they might use a pillowcase or something. Therapeutic fibs, such as, you know, your family has already paid for you to spend the night or have dinner or whatever. You might as well take advantage of it. These elders usually don't like to waste money. Falls. Every person with dementia will fall eventually. And the dementia diagnosis in and of itself is a predictor of falls. Always check for an organic cause, especially if they're not someone who would normally fall. If they're falling all of a sudden, there's something going on. Most common reason for hospitalization of elders with dementia is syncope, fall, and trauma. And they can't tell you, you know, I feel a little dizzy today. No, they can't say that. This is a study I found with some good information about how to decrease the number of falls in your facility. And they have 3 actions to reduce fall rates. Design a tracking system to monitor the elders who fall. So you're going to communicate and make changes in the care plans and the fall reporting process. What you're looking for is a pattern to the falls. So if you track every single one of the falls, what time, what were they doing, what shift, you're going to find a pattern, hopefully, somewhere in there. And you're going to be able to figure out how to alter that. Detailed timely reports, implement consistent reporting and signage programs. If half your staff don't know that George is now at increased risk of falling, they won't be watching him as closely as they should be to prevent the falls. So communication is crucial on this. On to dehydration. Here's what can happen to any elder who is dehydrated. Now, you look at this list, can you honestly say you're aware of all of these things that will happen to an elder who is a little bit dehydrated? You're aware of all these things, these negative outcomes? Well, if you are aware of them, is your staff aware of them? And if your staff is aware of them, do they care enough to prevent them? Okay? You know, we're all likely on the verge of dehydration. When we get that thirst signal in our brain, our kidneys are already thinking there's a drought going on. So elders with dementia can't, I mean, that mechanism has been disrupted or destroyed, and they can't really say, I'm thirsty. And so you can't just say, would you like some water? You just have to hand it to them. Helping them stay hydrated, some tips. Keep them calm and happy, that's easy, right? The more calm and happy they are, the more willing they are to do whatever you want them to do. Sometimes give them control. You know, they've lost control over just about everything in their lives. And we had one woman who, if you asked her anything, she would automatically say no, because it wasn't her idea. And so, to keep her hydrated, we would walk up to her carrying a pitcher of water or 2 glasses or whatever, and say, Esther, is that a new skirt you have on today? It's lovely. It just matches the color in your eyes. And, you know, while you're complimenting her on the skirt, you're handing her the glass, and you're taking sips of your water. And she's standing there talking to you. She can only focus on one thing at a time. And so it's automatic that she starts drinking too. So that kept her hydrated. Give water immediately upon awakening in the morning. This is the best way you will have of getting an entire glass of water into that elderly person with dementia in the morning. And you know what? Your staff don't want to do this because they're in a hurry to get them up and dressed and in the dining room for breakfast, right? It doesn't take long. And you'll be amazed at how much better they can walk and talk and feed themselves when they have a full glass of water on board. A lot of these elders are mouth breathers when they sleep. How good does that feel to drink some nice cold water when you wake up? So what they do, they walk into the bathroom, get a big glass of water, not one of those ditzy little things. Get a big glass of water, set it on the nightstand, waken them with a smile, help them sit up, hand them the glass, and then ask them, do you want to wear the red shirt or the blue shirt today? Get their stuff ready. By the time you're done getting that stuff ready, they may have finished that entire glass of water. This is huge. So think about instituting this for your facility. At least 4 to 6 ounces of water with every med pass. I've done it myself. 2 sips of water, pills are down, on you go. No, it doesn't work. These old kidneys are damaged anyway, and they cannot metabolize the medications on 2 sips of water. I would often say, your doctor said you have to drink this whole cup of water or your medicine won't work. And I had one woman who said, well then let the doctor drink it because I don't want it. So you do what you can. Keep their favorite beverages on hand, that might help. Beg, bargain, and plead. Water with every snack. You don't just ask them if they want it, you hand it to them. Always refill beverage glasses with water at meals. And again, your staff don't want to do this because they're in a hurry to get them out of the dining room, right? As soon as that juice glass is empty, put water in it. Even if they take 2 sips from that, that's 2 sips further away from dehydration for them. Do not get choices. People with dementia can't make choices. I mean, if you want to ask them, do you want the pie or the cake, that's fine. But you don't ask them when you don't want a no answer. Drink a glass with them, your kidneys will be happy. Final topic I'll talk about, malnutrition or weight loss. People with dementia will lose weight due to the dementia diagnosis by itself. So you don't want them to lose weight unless they're morbidly obese to begin with. These are all the things that can happen when a person with dementia or any elder who loses weight. This is all that can happen to them. You don't want any of these things happening. You don't want a malnutrition diagnosis on your chart. They die quicker, they get sick quicker, and the state wants to come in and see just what it is exactly you're doing to keep them from losing weight. So that's a liability. How to maintain their weight, some tips. Placemats. How many of you use placemats in your facilities? For people with dementia, it helps define the boundaries on the table for them. Now, there'll come a time when they just think it's something that they need to eat, and then you don't need to use them. But until that time, it makes it look nicer, and it defines the boundaries for them. Color of dishes contrasts with color food. People with dementia have vision losses. They cannot see white food on a white plate. Even a white sandwich on a white plate is not necessarily seen by them. They recommend blue dishes because we have very few blue foods. Serve 1 dish at a time. Studies have shown they eat much better. You serve 1 dish at a time. As soon as they're finished, take it away, replace it with the next one. Supplement drinks for snacks if they're losing weight. Favorite foods available at all times. Discourage staff from mixing pureed foods together. Yuck! Have you ever tasted that? Do you even want to taste it? And if your staff are doing this on a regular basis, have an in-service where you have them feed each other pureed foods all blocked together and see how they like it. This is the only social thing these elders have left. So don't ruin it for them by mixing it all together. If they say, no, I just had breakfast, I don't want to have another breakfast, and they haven't had breakfast, well, that's fine, but you know what? Bill and Mary will be really upset. They'll worry if you're not there just to visit with them. Just come and have a cup of coffee. You don't have to eat. Okay, so they sit down, you give them their coffee, and then lo and behold, you give them their plate. And whoops, I'm sorry, I forgot. Just let it sit there, I'll pick it up later. If their social graces are still intact, chances are, and everyone else is eating, they'll be eating. Finger foods. If they can't stay seated to eat their meal, you have to provide finger foods for them to help prevent weight loss. Sandwich foods. We had one resident who stopped being able to manage the utensils. She refused to be fed She'd clamp her lips shut, you couldn't get anything past her. Staff found that if you put something in a sandwich and handed it to her, she would eat it. So she got spaghetti sandwiches and broccoli sandwiches and whatever we had, she got in a sandwich. And she continued to feed herself. Assess for pain. Do they have chronic arthritis that's acting up? Do they have a sore in their mouth? Has a new med been started? How many medications cause GI upset? A lot. Always put food in front of them, even if they say, I'm not hungry. Oh, I'm sorry, I forgot. Don't worry, you don't have to eat it. Calm, pleasant, home-like environment. Assigned seating. Do you have assigned seating for your elders with dementia? You know, they might not be able to say, this is where I sit, but there's a sense of familiarity with the area and the people around them. And the more familiar things are to them, the more comfortable they are, the better they will eat. Seat higher functioning elders with dementia away from those needing to be fed. They don't want to watch people spitting their food out or eating with their hands. Nobody likes to watch that. So seat those higher functioning residents elsewhere. Music during meals. Elevator music, you don't want them up jiving during the dinner. Aquariums in the dining room, study showed. I don't know, this wouldn't do it for me, but it evidently works for people with dementia. Aquariums in the dining room that help them eat better. Jumpstart the hand motions. If they can't figure out what to do with the utensils, sometimes if you put their hand around the utensil, guide it into the food and up to their mouth a couple of times, they'll keep doing it. It's like jump-starting the muscle memory. And they can help feed themselves then for a while yet. Keep track of BMs. Are they upset because they're constipated? Physical exercise or PT, if that's ordered for them, do it before a meal so they have more of an appetite. Treat a depression. Definitely treat a depression in an elder with dementia. Appetite stimulants, Marinol, Elder Tonic. I used to say Megaze, but the 2012 Beers criteria came out, and they say that Megaze has a minimal effect on weight and it increases the risk of clots and death in elders. So do not use Megaze. Use Elder Tonic or Marinol, or put them in a sensory stimulation room, or something like that. In summary, you do whatever you need to do to keep your staff and your residents or your clients happy, safe, and treated with dignity. When you focus on achieving that goal for both the staff and the elders with dementia, you will automatically reduce the number of liabilities from families, from surveyors, and from the staff themselves that comes along with any elder with a dementia diagnosis. I think we're out of time. So if you have questions, please see me at my table. Thank you for your attention.